In the name of Allah, who is the most beneficial and ever gracious. Assalamu alaikum. This is Sayyida Aska Haroon of roll number BP 1650224 of 5th Prof Morning. My topic is Ipratropium Bromide and the course is PhD 705. Ipratropium, according to the introduction of Ipratropium Bromide. Ipratropium Bromide is a bromide salt form of Ipratropium, a synthetic derivative of the alkaloid ipratropium with anticholinergic properties. Ipratropium antagonizes the action of acetylcholine at parasympathetic prostaglandinolic effector cell junctions. Mechanism of action. Protopodium is an acetylcholinetic antagonist via blockade of muscarinic cholinergic receptors. Blocking cholinergic receptors decreases the production of cyclic guanosine monophosphate (cGMP). This decrease in the lung airways will lead to the decreased contraction of the smooth muscles. The action of intranasal ipratropium mimics the action of ipratropine by inhibiting the salivary mucus gland secretion as well as dilating bronchial smooth muscles. Compared to atropinium, orally inhaled atropinium is more potent antimuscarinic and bronchial dilators of smooth muscle. Intranasal ipratropium produces a local parasympathetic response leading to the decreased water secretion of mucosal glands of the nasal system, elevating systems of rhinorrhea, allergic or non-allergic. Indications of ipratropium bromide: it's chronic obstructive pulmonary disease (COPD). Chronic obstructive pulmonary disease is a chronic inflammatory lung disease. It causes obstructive airflow from the lungs. Asthma. Number second is asthma exacerbation. During an asthma attack, also called asthma exacerbation, the airways become swollen and inflamed. The muscles around the airways contract and the airways produce extra mucus, causing the breathing bronchial tubes to narrow. Minor and moderate bronchial asthma. Moderate persistent asthma is more severe than mild, intermittent or persistent asthma. People with moderate persistent asthma experience symptoms like chest tightness or pain. Rhinorrhea. Rhinorrhea is a free discharge of thin nasal fluid. The condition, commonly known as runny nose, occurs relatively frequently. Rhinorrhea is a commonly symptom of allergies or certain viral infections such as the common cold. Adverse effects are bronchitis, nausea, mouth dryness, skin flushing, dyspnea, symptoms of common cold, dizziness, sinusitis, dyspnea, hypersensitivity reaction, and paradoxical bronchospasm. Irrational use of ipratropium bromide. Irrational use may cause chest pain, fast or pounding heartbeats, tremors, dry mouth, extreme thrust, muscles weakness or limb feeling, severe headache, pounding in your neck or ears, or feeling like you might pass out. Keep the spray solution away from the eyes. This medicine may cause eye pain or discomfort, irritation, blurred vision, or start seeing halos or odd colors when you look at things. Closing your eyes while you are inhaling ipratropium may keep the medicine from getting into your eyes. Drug interaction. The interaction with the anticholinergic like tricyclic, antidepressant, antiparkinson drugs, and quinine, which theoretically increase side effects, are clinically irrelevant when ipratropium is administered as an inhalant. Serious interaction of ipratropium include perimethylidine. Mild interaction of ipratropium include diamethionate, levodopa, taurine, galantamine, and danazepam. Toxicity. High dose of ipratropium can cause toxicity similar to cholinergic, anticholinergic toxicity symptoms. These symptoms include hyperthermia, agitation, confusion, mydriasis, mucosal dryness. Reports have demonstrated ipratropium versus ischemic injuries in non-conus settings. Alternatives of ipratropium bromide are atropine nasal. It is usually prescribed for rhinorrhea, diltiazem prescribed for insomnia, allergic rhinitis, allergies, conjunctivitis, allergic nasal congestion, rhinorrhea, and upper respiratory tract infection. Albuterol is a rescue inhaler that is used to the people with asthma to help them better breathe and when they are wheezing or have shortness of breath. Brands of ipratropium bromide are Atrovent, and its dose are metered dose inhaler 17 mcg plus equitation nebulized solution 0.02%. Extra variant HFA 2 inhalations 4 times a day. Ipratropium inhalation solution unit dose vials contain 500 mcg 22.5 ml NS. Dosage adjustment. Usual adult dose inhalation aerosol 2 inhalators 3 mcg orally 4 times a day or as needed up by 12 inhalations in 24 hours. Nebulizer inhalation solution 500 mcg 3 to 4 times a day by oral nebulization with dose 6 to 8 hours apart. Usual pediatric dose nebulizer inhalation solution less than 12 years. Safety has not been established. Basically 12 years or older 500 mcg 3 or 4 times a day or molar or oral nebulization with doses of 6 to 8 hours apart. Now as we further move, we will discuss about regarding a case study about our main topic, COPD. Jack Smith is a 74-year-old man who presents his family medicine office with his wife complaining of shortness of breath and fever. They just moved to the area and had been planning to come to our office next week to establish care as new patients. Due to the onset of system, he was called and was given to walk-in slot today. His wife did bring his records from his past physician office. Jack Smith's current symptoms include the following: unable to speak the full sentence for the past 4 hours, cough productive but unknown color of symptom, audible wheezing since last night according to the wife, mild chest tightness, dysphagia. His wife has noted no change in his alertness or mental state. When you inquire, the wife states that Jack Smith usually has a cough, worsen in the morning, productive of a grey sputum, shortness of breath if he walks more than 10 feet, and has episodes of wheezing if he gets sick. Our subject is his chief complaint is the shortness of breath according to his past history: heart failure following a myocardial infarction at the age of 68 years, COPD on 2L home oxygen, hypertension, and appendectomy. Treatment history: where he was taking amoxicillin 2 courses 2 times according to the courses and doxycycline 1 time according to the course. Most recent course was 6 weeks ago. Objective physical exam. According to the physical examination, he was unable to speak in full sentences, audible wheezing, alert and oriented. Patent positives: journals are audible wheezing, non-necessary muscle use, chest increased at posterior diameter, diffusivity wheezing to acceleration, heart is regular, no murmurs, and according to the chest X-ray shows the hyperinflammation and right lower lobe pneumonia. Vitals: BP are 128 to 74 and it's regular, R 32, height 5 feet 6 inch, weight 122 lbs. The temperature is 101.5 degree Fahrenheit. Oral pulse oximetry is 86%. And according to the assessment, based on this information, Jack Smith has following the clinical factors that increase his risk of severe COPD excursion: marked increase in symptoms and change in his vital signs, including a lower oxygen saturation, a new medical comorbidity of pneumonia, all combined with the severe baseline COPD indications for hospitalization, risk of death from an oxygenation increase with development of respiratory acidosis, presence of significant comorbidities, need for ventilation support. And for pharmacological treatment, we describe him as lisinopril 20 mg twice daily, metoprolol 500 mg twice daily, spironolactone actone 25 mg daily, furosemide 40 mg daily, escalmetal fluticasone 50 to 500 dry powder inhalator, DPI 1 puff inhaled twice daily, albuterol or ipratropium metered dose inhaler basically, or a solution for nebulization every 6 hours as needed. Non-pharmacological treatment: avoid smoking, avoid tough exercises or any exercise which affects and causes him shortness of breath. Notes: over 3 days, Jack Smith has significantly improved and has weaned back to his home oxygen regimen. He is taking the 11 Protopodium nebulized treatment every 6 hours and is ready to switch back to the bronchodilators via inhaler device. Along with the antibiotics of a total 7 days, we have to determine the dose and duration of treatment of oral corticosteroids. And the references are Kedgen and Trevor Pharmacology Examination and Board Review 11th edition, Lippincott Illustrated Review Pharmacology 6th edition, Ipratropium Bromide 2nd edition, Diagnosis and Management of COPD, including the cases for discussion. Thank you. Have a nice day. Allah Hafiz.